Good morning, good afternoon, and good evening, everyone. Chronic pain conditions place individuals at an increased risk of social isolation, smaller social network size, and reduced social role functioning, all of which have negative implications for pain interference and pain intensity over time. I'm Dr. Gabby Caspo. I'm the moderator for this event. I'd like to welcome you all from all around the world. Thank you for attending this unique webinar. I want to introduce Dr. Mariona Mollet Paredera, our lead host for this event. I also like to thank the panelists for their time to be here with us and to share their experience and opinion. I want to thank the American Academy of Orofacial Pain for sponsoring this webinar. We are lucky enough to have Dr. Jeff Schaefer, the president of the American Academy of Orofacial Pain, part of this panelist. Now, I would like Dr. Schaefer to open the webinar.
Well, thanks, Gabby, for an opportunity to say something to the group. It's hard to see how many of our members and others are attending today's webinar. It's a great turnout, and it points to how important it is for us to communicate to each other how we are handling the challenge of the pandemic. It's almost been a year that this pandemic's been affecting us. It also underscores how important organized dentistry is, organized dentistry and medicine. Organizations such as the CDC, the ADA, and also the American Academy of Orofacial Pain, into providing information on how to keep ourselves, our patients, and our practices healthy. I want to thank Gabby Caspo for coming up with this idea for the webinar. It's been very well received, and I think that's awesome. And also Dr. Mariana Mollet Padera for organizing and doing some of the hard work and heavy lifting for this program. And also, to our panel who has agreed to present today. I'm really looking forward to the discussion, and I think it's great that we can all communicate today on a rainy Saturday in Boston. Thank you.
Anna?
Good morning, everybody. I'm very excited to work with our panelists today on this discussion regarding COVID and how it has affected our orofacial pain practices. And I will be introducing the speakers first. Just a comment on the questions and answers. If you could direct those to Gabby and I, Dr. Caspo and I. We will be asking questions to the panelists through the session today. So we'll try to keep an eye on the questions, but we'll mostly be looking at them towards the end of the presentations, and we'll try to give plenty of time for the question Q&A. So I'll start by introducing our first speaker or panelist, Dr. Daniel Manfredini. Good afternoon, because he joins us from Italy. Dr. Manfredini received his DDS and MS in occlusion and craniomandibular disorders from the University of Pisa in Italy. He also completed a PhD in dentistry from the ACTA in Amsterdam, as well as a postgraduate specialty training in orthodontics from the University of Ferrara in Italy. He was an assistant professor for about 10 years and coordinator of research projects at the TMD clinic of the University of Padua in Italy through 2016. And currently he is at the University of Siena in Italy. He teaches in oral physiology and in clinical pathology at the School of Dentistry there. He was appointed full professor by Scientific Merit in 2017, and he has authored more than 200 papers in the field of bruxism and temporomandibular disorders. Today, he will be able to share with us his perspective in treating patients with COVID or during the pandemic, as well as the results of a large survey that he has conducted related to the pandemic and sleep bruxism. So we're looking forward to seeing that. Sounds very interesting. So welcome, Dr. Manfredini. Our next panelist is Dr. Jeff Crandall. He joins us from Vermont today. Dr. Crandall completed his dental training at Temple University School of Dentistry and a general practice dental residency at the Medical Center Hospital, both of those in Vermont. After that, he completed a certificate program in the diagnosis and management of temporomandibular disorders at the University of Medicine and Dentistry of New Jersey. He's a diplomat of the American Board of Orofacial Pain and a fellow of the American Academy of Orofacial Pain and the International College of Dentists. He's a past president of the AAOP. Dr. Crandall has served on the board of directors of the AAOP as well as the board of directors of the American Board of Dental Specialties. And he has presented many programs on a local and national level. In the 1990s, Dr. Crandall served a major role in the legislative process that resulted in a revision of Vermont's law that improved access to care for patients who experience orofacial pain. Dr. Crandall has maintained a referral-based practice limited to TMD and orofacial pain since 1984. And today he will share with us his perspective of practicing in private practice during COVID. Welcome, Dr. Crandall. Our next panelist, Dr. Richard Cohen, who joins us from Arizona, not the Arctic. He completed his DDS at the University of Tennessee School of Dentistry and his TMD preceptor program from UCLA. He is a diplomat of the ABOP, a diplomat of the American Academy of Integrative Pain Management. He's a fellow of the AAOP, a fellow of the American College of Dentists, and a fellow of the American Headache Society. He is a past president of the AAOP, past president of the ABOP, and currently a site visitor for CODA. He has a long history with leadership with the AAOP. And currently he's an adjunct faculty at the UCLA Orofacial Pain Residency and has been doing so since 1990. And he also holds private practice limited to orofacial pain and has been doing so for about 30 years in Phoenix, Arizona. So he also brings us the experience of private practice as well as teaching at a residency program, and he'll be able to share some interesting information with us today. So welcome, Dr. Cohen. Our next panelist, Dr. Sherwin Armand, joining us from Los Angeles, California. He completed his dental degree from Boston University Goldman School of Dental Medicine. He then completed an advanced education in general dentistry program from the University of Southern California. Later, he completed his orofacial pain residency program from UCLA and a master in public health from UC Berkeley. He's a diplomat of the ABOP, a diplomat of the American Board of Dental Sleep Medicine, and currently an oral examiner for the ABOP oral examination. He's currently the program director at the UCLA Orofacial Pain Residency Program, where he's also involved in research. Additionally, he's in private practice, which is limited to orofacial pain and dental sleep medicine in Mission Viejo, California. Dr. Armand will be able to share with us his perspective on both private practice as well as seeing patients at the university setting and teaching at an orofacial pain program during COVID. Welcome, Dr. Armand. And last but not least, Dr. Ian Boguero. Different from our other panelists, he is a psychologist and he joins us from Lexington, Kentucky. He is the Director of Psychological Services and Director of Research at the University of Kentucky Orofacial Pain Clinic. He completed his undergraduate education at UCLA and received his PhD from clinical psychology at the University of Kentucky with a graduate certificate in statistics. He also completed a 2-year postdoctoral fellowship at Cincinnati's Children's Hospital Medical Center. His research interests are in developing brief psychological interventions for improving pain and fatigue in patients with chronic pain. His work has been funded by the NIH and the American Psychological Association, within others, and has been published in top pain journals. We're very happy that Dr. Boguero is joining us today, as he will share his perspective on how the pandemic has affected his patients. So with that, Dr. Caspo, is there anything else that we need to discuss before we start our panel discussion?
No, just really for the questions and answers should be submitted to Q&A. Everyone will get 1 hour and a half of AGD credit for continuing education after attending at least 30 minutes of the webinar.
Perfect.
You can start. Thank you very much, Marijuana.
Thank you. So we'll start. We hope that this is a conversation and some questions will address to the whole group, some questions to specific panelists. So feel free to jump in and just remember to mute your microphones when you're not speaking. So the first question, we would like to know, how did COVID and the pandemic impact your orofacial pain patients? What were some of the biggest challenges that you encountered when starting seeing patients during the pandemic?
I can start. Over at at UCLA, early on, in March, really everything came to a standstill. Patients really didn't want to come in, and this was at a time where we didn't really have really firm guidelines either. So I think everybody was really concerned. So this wasn't early on. This wasn't a situation where we had strict guidelines. Frankly, really nobody really wanted to leave the house. As things progressed over time, patients have become more comfortable. I think like if it was practical to do so, we could fill the schedule again. Of course, we don't. We have a lot of guidelines where we use every other chair, and we screen patients at the door. And when patients sit down, we check their temperature a second time. But early on, it was, I think, for maybe a month and a half, we maybe saw, one patient every other week who had a very significant emergency that needed to be treated for pain. But right now we have a steady flow. We have guidelines, of course. We have screenings, and so things are. I don't want to say they're back to normal now, but we do have some sense of normalcy currently with treatments. I can't say that we're limited currently with what we can do in terms of procedures.
Very good. And the question too is, how differently were those protocols between university settings and private practice settings? And was the timing to get going different? How did that affect the ability to see patients, the availability of PPE? Yeah.
I'd like to add to Dr. Armand's comments. Being in a small private practice in Vermont, as opposed to, say, California or Arizona, our demographic is quite different. I have been looking at the numbers, comparing Vermont with California and Arizona, and it is remarkable how different our demographic is compared to the other states. We're looking at a situation in Vermont where we might have 100 cases a day, as opposed to 10,000. We may have 2 or 3 or 4 deaths occasionally in a day, as opposed to hundreds in other locations. And so that has had a huge impact on the way we provide care for our patients, which I'm sure is different from Dr. Armand and Dr. Cohen. Maybe Dr. Cohen would care to comment from his perspective.
Yeah, you have to unmute yourself there.
Yes. So overall, we had 2 perspectives, because I'm pretty active also at the Orofacial Pain Clinic at the dental school in Mesa, Arizona, where I run the pain clinic there. And so at the beginning of the epidemic, then we had closed the dental school except for emergency procedures. So we did everything with telemedicine, which we'll talk about later in the program, but that was very key, and be interesting to discuss how we did that. In the private practice, then it was open. The governor in Arizona said only essential services, but since a lot of our patients had acute pain, then the practice was open to see the acute orofacial pain patients, and the ongoing patients that needed care injections and so forth, especially nerve blocks and trigger point injections. So those patients continued to come in. PPE was the biggest problem because at the beginning it was very hard to get gowns, N95 masks, and shields. And so I didn't go in at all because of my young age. And so I did everything on telemedicine for 3 months. And the younger members of the staff and faculty at the school went in on a very limited basis. And then referrals were slow because the dental practices were pretty much closed and medical practices weren't seeing very many patients. But then toward June, then as everyone started opening up, then everyone who had been waiting to see us and calling in pain, calling in some prescriptions for patients who were in pain and had to wait, then we had a flood of patients and had a big backlog. And then I started going in once we had PPE and doing things that we could do there. Along the line that I was going to also discuss, then how did we handle things like aerosol procedures, whereas you think that we don't do a lot of drilling inside the mouth, we are adjusting appliances. And so we had everyone wear masks, patients were wearing masks while we're interviewing them all the time, except when they have to actually take the mask off to look inside, which was limited, and then we wore shields. But then for the appliances, then we'd have the patient rinse with peroxide rinse, and sometimes we would spray the appliances with Cavicide, the 1 minute variety, so that it wouldn't take very long. And then we had at the school, we had a box with vacuum attached where we could attach suction and do some adjusting the appliances inside this vacuum box. So we were trying to be as safe as we possibly could. And so overall, the patients did receive pretty good care and continue to get that now. Although the survey only covered through December, now that Arizona is the highest rate in the country, then we've had probably 50 to 60% cancellations and no-shows now.
If I may comment, we don't have the same problems, obviously, because we're in a different environment here, but we still use the same precautions. One of the things that we have found extremely helpful is the anesthesia boxes. I'm not sure if you're all familiar with that, but these are boxes that are used by anesthesiologists so that they can access the patient in preparation for administration of general anesthetics. And they have 2 holes on the back and an open end at the front for the patient's head, so that in a sense there is an isolation established by that device. We've modified it for our purposes so that we can access splints in a confined space, and the area that is open in the back is draped with a clear plastic shield so that it can be cleaned up and sprayed down after each procedure. We found that to be at least comfortable, I guess you would say, in our environment. Do you do something like that, Rich?
The box isn't totally sealed, so it's the suction is the best thing we have to pull things out, and then of course the rooms are totally disinfected after each patient, both at the school and in the private office. And then for our own protection, anything that's on my clothing or anything else is that when I get home, I'm in the garage, I get everything off and into a bag, and all that goes straight into the washing machine, and then I go inside and shower and put on new clothes before I go in the house, so that I'm not transmitting any of that dust or anything we got from the clinic into an environment. And the car gets totally disinfected for anything I was in every day too. So it's a matter of, because we don't have total control over that dust of when we adjust appliances, then that's a way we've been trying to protect everyone.
I'd like to ask Daniele about his experience in Italy. And
Thanks, Gabby. I was about to intervene because here in Italy, the situation is pretty different. As you may know, we closed earlier than everyone because if I remember well, we were stopped around March the 8th or 7th, okay? And especially in the public institution, in the university, we got closed, and many are still closed unless you must do emergency procedures. So basically, there is a difference between the attitude also of the patients toward the university settings and the private settings, because dentists, so not only orofacial pain practitioners, but dentists here basically have never been forced to close, but just recommended to perform only urgent procedure. So it's been pretty weird to see that during the first weeks of the quarantine, the attitude of the patients was, hey, I have pain, I want to come. And the problem was ours to track the patients, to provide with the protection disposals, because for instance, here, just the very simple KN95 masks, which cost less than €1, arrived to cost €8 or €9 each. Okay, so that's crazy as a speculation. Then we lived a second phase, in my opinion, in which no one wanted to get out of the house because of the fear of contracting the virus, even in the air. Okay, so not only in the dental offices. And now again, especially after the summer, even if now we are living a soft quarantine, I don't see any real changes in the patient attitude. They want to come, they want to be treated. So there is a very large difference between the public and the private setting. So in the private setting, everything is demanded to our ethics and our self-control.
thank you.
I do have a question actually for the panel. I think we touched upon this briefly yesterday about how, in orofacial pain, we don't perform many aerosol procedures, but that definition of what's an aerosol procedure kind of varies. So my question is, starting with Dr. Cohen, what is the definition of an aerosol procedure in Arizona, in the university you're at? And what are the guidelines for when you have to use an N95? Do you have to use it all the time?
Well, the guidelines that are set at the university, AT Still University, where they have pretty strict guidelines, is that any drilling procedure is aerosol, and cavitrons were actually eliminated for most of it. So they didn't use any cavitrons. And then each operatory had to be isolated because it was open bays. And so they had to isolate. I insisted that before I came back in, we have private rooms. And of course, for interviewing pain patients, we liked it that way. So we had what we call quiet rooms. So I insisted that all the pain procedures be done in totally isolated rooms with the air filters. And we had air filters at the HEPA filters at the base of every chair. And then for the school, then also grinding on appliances or the dentures or whatever they were grinding on, that was considered an aerosol procedure at the dental school. And so they had the HEPA filters, the isolation. And as far as N95 masks, because of my age, I wore N95 for everything. But for the rules of the clinic and the majority of faculty, they wore just a level 3 mask. That was required a level 3 mask if you were just talking to a patient or doing something that was not aerosol. But for aerosol, you had an N95 plus a shield.
Yeah.
I think it's interesting. I could comment on what happened at Mass General Hospital. I think it's interesting. One of the criteria, we had all different kinds of clinics, and really it depended on the room exchanges in the clinic that dictated how often you could see a patient and how long you had to wait between an aerosol generated procedure. So initially, in our clinic, you had to wait an hour. So if you had an aerosol generated procedure, and for us, that would be adjusting an appliance, then you had to wait an hour in between patients to have another patient in that room. So that was really constricting. That gradually changed because we added a bunch of operational changes with air purifier in every room, which increased the room exchanges, which was big. So that made us, if we have an aerosol generated procedure now, we have to wait 15 minutes in between procedures. And really the only aerosol generated procedure for us is the adjustment of an appliance. And so there we have to wear N95, put a second mask on. We have to have a face mask for, a face shield rather, for every procedure, any encounter. But it's just really the adjustment of the appliance that requires us to take precautions as an aerosol generated procedure.
So now that PP is a lot more widely available and protocols have been more solidified and established, then the question is, are people compliant with these protocols? How is this affecting staff, students, and what is our role in ensuring that these protocols are followed?
I think it's fair to say here in Vermont that everybody is very much compliant with the masking requirements, the quarantine requirements, and so forth. So I'm not sure I have a heck of a lot to add along those lines. I am curious, though, if the panel could give us an idea of how frequently you see someone who's tested positive and either in recovery or has recovered from COVID. Do you see these people on a regular basis?
We certainly did not have many because they had very good screening, both in our office and the school. The temperature checks, the filling out of the paperwork every time. At the school for a while, we were even taking oxygen saturation because there was some evidence that any decrease in oxygen sat would be a sign that the person had COVID over and above the temperature and cough, etc. So how good the tracking, however, is as far as which patients ended up having COVID that we never knew about, that's a whole different story. But the national statistics that were given to our dean were that as of a month ago, there were no known transmissions from a patient to a dentist in any office or school in the United States at that time. So apparently our precautions, either our reporting is bad or the precautions are working very well, because I'm sure we're seeing patients that have COVID that we never found out about.
Mm-hmm.
Yeah, even in Los Angeles, I'll say that at UCLA, we do phone screening. So we screen patients even before they come. They're screened at the door with a temperature check and questions. And then when they sit in the chair, we take their temperature again and ask them a whole bunch of all the COVID questions again. Actually, and we haven't had any clusters, at least that I know of, any in the school at all. And this is Los Angeles. So I think it's a testament to it. I think it's been pretty effective. In terms of PPE, again, we seem to be pretty stocked up right now. We have access to everything. And just like other universities, we use N95s for mainly the aerosol procedures. And I'll say that with adjustment of appliances, that's not considered a true aerosol procedure. But you certainly could wear one if you wanted to. So right now we don't have any shortage, at least, with any PP.
Back to Jeffrey's question, I fully agree with you. The right answer in an ideal world should be 0 patients with COVID if the screening works well. We also have a phone screen, so the secretary are instructed to ask some questions. So in theory, of course, for what we know, we didn't see any patients who was actually positive at the moment of the visit. But the real question to me is for the panelists, do you have any statistics about the number of dentists who have contracted an infection? Because here in Italy, it seems that we are not actually at risk as a category.
Well, that was the result of the study that was given to our dean back in December, that there were no cases in the United States where a dentist had contracted the virus from a patient. We had students contract it outside and then spread it to each other. And that caused a big change in how the staff had lunch. So after that occurred, then no one was allowed to have lunch inside with other people. They had to eat outside, which is fine in Arizona where it was 79 degrees yesterday. But that might be a little difficult elsewhere. Or they would say there had to be no more than 2 people in a room separated by 6 feet with their masks off. But I'm not sure how well that works. But so far, there's been no reported cases of transmission from a patient to a dentist in the country that as of this in December.
Great.
Let me ask another question quickly. Does anyone ask about anosmia in your patients? Loss of sense of smell? No?
Okay. Part of our initial questions when they're either allowed into the clinic or not. So we have a series of questions we ask.
Okay, so you do ask that.
That is at the school they do. I don't know about our private practice.
In our hospital, in order to get a COVID pass to see patients, we have to answer those questions. And the patients answer the same questions. That's one of the questions: is any loss of taste or smell.
Now, something that might be helpful for offices that are having problems with PPE, since the research isn't that great on how long you can use them, the last thing we did based on research at the school is they rotate N95 masks that they can be worn 3 times, separated by 3 days, stored in a sealed paper bag. So that way they get a lot more use out of the mask because we don't have enough N95s. It was cost as well, but just getting them was difficult. They also have a facility that they refurbish the N95s, and that can be done up to 5 times. That seems to be fairly effective. But, that kind of research changes by the month. But that's one way to preserve the N95 masks is by rotating them if they don't get wet or soiled.
Great. If nobody else has any other
I was
comments.
wondering if anybody else had experience with how they're dealing with it. How long do you wear an N95 before you go to another one? Do you always change? You could change twice a day, once a day. How are people doing that on the panel?
At UCLA, I believe I know that they're sending them for ultraviolet light. They sanitize them that way. They're shipped out and they're returned to the user.
And how long at UCLA? How long are you using the mask? If you start out the day with one mask, you use that just that day. You use the half day. How do you do that?
Yeah, if it's not visibly soiled, I believe you could continue to use it and then and continue to use it. If it's not soiled.
We've gone to 1 per day, both at the hospital and also at Harvard School of Dental Medicine. So then we dispose of it. But we did initially do the process where we send it for being refurbished, and you would get last week's supply back the next week, and we did that for a number of months. But now it's just 1 per day, and then we dispose of it.
For me, it's 1 per half day. And then go to the rubbish.
There's a pretty wide variation on how they're used, and also the cost. So apparently, but most of you don't have any problems actually getting N95s. And the cost is still about $5 a mask in the United States. Used to be.
About that.
Alrighty, I think I'm going to suggest that we move on to the second topic, and this will be more related to patients' symptoms themselves, and what your experience has been regarding any observations regarding their symptoms. Has there been an increase on patient symptoms, exacerbation of symptoms as a result of the pandemic? And what types of symptoms?
So I can start off speaking from a psychological standpoint. One thing I'm seeing a lot in my patients is a significant increase in the amount of stress and anxiety, and a lot of this is COVID related. I'm also seeing a little bit of an increase in depression symptoms, but primarily stress and anxiety are the two symptoms that I'm seeing a major increase in. I've also seen some patients who report more parafunctional jaw habits as a result of having their mask, and specifically they're primarily work in a setting where they have to have their masks on throughout the day. And patients report to me that they're moving their mouth a lot to adjust the mask, and that's contributing to increased pain. So from a psychological standpoint, that's what I'm seeing a lot of, and also much more disrupted sleep. Possibly due to the increase in the stress and the anxiety as well.
I have a question for you. Is the depression secondary to the increase of anxiety, or this is different story?
It's hard to say. We do see that those two are correlated a lot of the times, but we're also seeing that COVID has caused people to, a lot of times, a significant change in their routine and in their structure, and sometimes in their role. People haven't been able to do the same roles that they were doing before. So it's really hard to say what's contributing to the increase in depression. And my best guess is that it's all of it combined. It's a change in their structure, an increase in anxiety, potentially an increase in pain can also be contributing to that as well. And a decrease in health behaviors, poor sleep, not as much exercise. And I think all of those may be playing a role there.
Have you noticed any changes in the patient's age group, young patients versus adolescent versus adults?
I haven't quite noticed that particularly. I'm seeing an increase in these symptoms in patients from all the age groups. I know that for some of my adolescent patients, having to do school virtually has presented a significant stressor, but I feel like every age group has their own significant stressor. For middle-aged patients, having their kids do school virtually has presented a significant stressor. So I'm not from my clinical experience, I'm not seeing that this is impacting one age group more than another particularly, but I'm not specifically looking for that either.
We also see a lot more patients or people working from home rather than going to their offices. How do you all think that this has impacted orofacial pain?
Well, one of the things that we've noticed is with the increase of use of computers, then we have a lot more tension, headaches, a lot more cervicalgia, because the students are on the computer more, the parents helping them with it are on the computer more at weird postures, and definitely a lot of people working from home then are working on computers with all these Zoom meetings and, tremendous amount of work being done on computers. So this creates a lot of extra stress on the cervical system, and then they're clenching a lot when they're on the computer. So we definitely had patients had an increase in these types of symptoms. We had to work with them a lot on posture and, moving around while they're on the computer. So that, it's an old problem that we always had, but it's a lot worse. And that can certainly continue.
Maybe Dr. Manfredini, you could share with us some of your observations regarding your survey and others that you might
Of
want to share?
course. Thanks. I try. I cannot share my slides, Gabby.
Yes, you can. Let me see if I can give you all. Okay, I'm giving you the host.
Okay. Here we are. I guess you can see the screen. Just a brief introduction. This was a survey that we launched with our Italian study group on orofacial pain and cranial-mandibular disorders just before Christmas. We sent it out to the patients basically. So we asked our members and also via the socials to share a questionnaire with their patients. As of this morning, we collected 446 answers, and the answers to the very basic questions are pretty interesting. Because basically you can see the pie charts. The blue answer is yes, no is in red, I don't know is the orange, and green is I never did that. So we didn't record more sleep time teeth grinding. We record much more sleep time teeth clenching, so as a possible result of anxiety and that kind of stuff, and especially during wakefulness. So we have a report from our patients of an increase of awake bruxism in the form of bracing and teeth clenching. You can see that basically half people, 49 and 47% respectively, declared that they braced and clenched more during the pandemic period. As for symptoms related to possible bruxism, no particularly relevant increases in mouth opening difficulties upon awakening. Some increase in the report of other oral behaviors, as Dr. Boguero suggested us a minute ago. And then again, about the symptoms, headache, Dr. Cohen already touched upon this possible issue. Then muscle pain, 35.9% of the patient had an increase in their muscle pain, and 31% more TMJ pain. No particular relevance of increased tinnitus report, but here we go, very high percentage of patients reporting disturbed sleep and difficulties in falling asleep as a possible result, or at least as a comorbidity of an increased sense of depression and melancholy. So basically, I think that these data quite clearly pointed towards the need of evaluating the role of psychological issues in our pain patients, which is something that we all know pretty well. But as I anticipated you yesterday during our talks, paradoxically, at least for our staff, during this period, it's been easier than before to convince the patients about the possible role of psychological tension and anxiety and stress sensitivity in the onset, or at least as a target for pain management. And this led to a possible increase in pain medication prescription, which is something that at least in Italy sometimes is still stigmatized. But that's our experience. And if you have any comments on how to refine this data and maybe conduct a multi-center study, they will be welcome.
It is very great. It's great presentation, Daniel. And I'd really like to share with you also, if you can give me to share my screen, my experience with the survey that I sent to the members of the American Academy of Orofacial Pain. I did, let me see. So we did almost the same questions about the experience between June and December when the dentist went back to practice. The majority of the dentists went back in the United States after May, by the end of May or June. So the majority, one of the questions was about during the period June to December, have you noticed any changes in your new patient's gender? It seems like the majority is no change, so the same between females and males. Also, the changes of age. In my private practice, I noticed I'm seeing younger patients, but this is the majority of the changes is between 30 and 49. Regarding the patient's symptoms, which I think all agree on the masticatory muscles pain, myalgia was the highest number of symptoms patients report to our members. Also, we have to really to bring the attention, and I'll ask you guys for your opinion about neuropathic pain, which is we may not consider it as a symptoms patients will report during the stressful events. So this also about the new patients. The previous one was our own patients, and now with the new patient that called in, and the myalgia was the highest number of symptoms they report. Again, neuropathic pain was one of them. Regarding to headaches, tension type headaches, which really is very important because of the myalgia and the cervicalgia that the patients, or the stress or anxiety that they experience. Paroxysm, anxiety, and I agree with Dr. Biguero about the anxiety level. Depression was not high, sleep disturbance was also higher. So we see the increase in anxiety was considered one of the factors that we see our patients report to us. Again, new behavioral symptoms. So our patients already developing new behavior issues, the anxiety. So these are really mostly what we are seeing here. So I would like to see if what you think the rest of the panel about the patient's population and their practices.
Gabi, if I can complement our presentations, which by the way are complementary, I think that the data which are actually lacking now are about the possible increase of these patients' population, because for us, or at least for me, as pain practitioners, it is not easy to understand if the absolute amount of patient is increasing or not. Okay, so we should collect data from our fellow general dentists and understand if they are referring more of those patients to tertiary clinics.
Thank you.
I'd like to add that here in Vermont, and of course, this is Vermont, not Arizona and California, but here in Vermont, we're seeing a lot of patients who are far more, shall we say, consistent about their care. They acknowledge the fact that what they have is influenced by the world that we live in these days, rather than being in a state of denial. And I think it has made it a lot easier for us to deal with these situations that patients encounter. I mean, we talk about COVID and how that's influencing our patients' lives, but so many of them have had multiple other anxiety-inducing factors that they haven't really confessed or recognized or identified. And I think that Dr. Biguero can kind of confirm the fact that now maybe it's a little easier to talk to these people about these factors and give them some tools to manage them better.
Absolutely. And I'm glad you brought that up. But as I look at this data from Dr. Caspo and Dr. Manfredini, what it begs the question to me is, as a practitioner and as someone who's seeing these patients, what can be done to help these patients who are experiencing an increase in stress and an increase in anxiety and an increase in depression? And I think that there's some very concrete things that can help and that we can recommend to these patients that is likely to help. For example, one of the things that the pandemic has caused for a lot of people is a major shift in their daily routine. And what we find from a psychological standpoint is that doing things that help maintain the routine and keep structure to the day has a major role in anxiety and depression. So recommending to patients that they still get up at a regular time, even if they don't necessarily need to because they're working from home, doing all the same things that provide structure to the day can a lot of times help with anxiety and depression. And that's a pretty concrete recommendation we can make. Another one is to continue doing the things that before the pandemic were helpful, but that now life seems too chaotic to do, and to try to reinforce them to continue practicing good sleep hygiene, good exercise, relaxation technique. And a lot of times what I talk to my patients about is not so much how can we take things off the to-do list, because a lot of times that's how it feels. The to-do list is too long and we have to take things off. But how can we add positive things to the to-do list? Sometimes adding more positive things is a very effective way of reducing stress instead of taking away negative things. And as was already mentioned, psychology in general, not only in pain settings, but throughout the country, regular therapists have seen a major change where now most psychological settings are at least offering telehealth. So that has practical implications for a couple reasons. One is because if you work in a setting that's more rural, and patients a lot of times never had access to good psychological care, now they can really see anyone in that state, and there's not a lot of geographic restriction. So having resources to patients and encouraging them to go see a psychologist anywhere in the state, there's just a lot more access to care now. The second thing is because patients are doing this from home, there's a lot less stigma associated with that. And as the panelists brought up, I think patients are more willing now than ever to actually engage in psychological care that maybe they were not engaging in before. So I look at this as a window of opportunity for dental practitioners to really help navigate patients towards the psychological resources that are likely to help them. And there's tools, and I can share this in the chat for how to find therapists in your area. There's a website where you put in your location, and you can have a list of providers in your area or in your state, which you a lot of times giving that to patients helps reduce the obstacle of finding someone.
I have a question. Sorry.
Go ahead, Mariona.
So I have a question regarding the timing of patients' symptoms. We are now 10 months into the pandemic, and you probably started seeing increase or changes in patient symptoms right away. How does that compare then and now? Have patients become more resilient, or have they adapted, or by contrary, have they become more anxious with time? Also seeing that the pandemic is not going away, it's going to continue going for months, if not longer. So are patients getting better or worse with time?
I would add something that's important just as a background, is to say that we're actually not seeing the most stressful group, and that's the unemployed, the people who lost their jobs, they don't have insurance, they don't have any money. So the statistics that we're looking at as far as the effect of stress on pain is we're not seeing probably a huge section of those. We're only seeing the ones that can actually afford to come in. But yes, it's, we're definitely seeing everyone is stressed from COVID, and of course, in the United States, they're stressed over a lot of political unrest right now too. So it's going to be hard to separate those two, considering what's going on in the United States with that as well. But all my patients are talking about the additional stress and how that's affected their pain, and it's. I definitely feel, although I don't have statistics, and I'm glad that some of you do, that there's no question that as it lasts longer and people are way beyond their expectations that this should have been gone, it adds to the anxiety, depression, and their pain is harder to manage.
I agree.
Just to go back a little bit, Mariona, I'm not sure about your experience. In my practice, these days, my majority of my patients, more than probably about 50%, or I don't have the statistics, are teachers. And I see most of the teachers who are working with special need students have higher rate of anxiety and stress. And I'm not sure really about the other practices, the panelists and this group here, if they notice any increase in number of the teachers as patients versus other profession.
Include nurses on that one too, I think.
That's correct.
Oftentimes, nurses are affected at increased levels.
Okay, thank you.
Very good. I'd like to ask about treatment plans, if the pandemic has affected the types of treatments you do, and then also has it affected treatment outcomes, how well patients are responding to those treatments. And the first thought there is, if there is an increase in sleep bruxism, are we making more splints for our patients than we did before? Anybody that would like to answer that?
Complex questions in the sense that we should comment on the treatment of Braxton, so please stay away from it. My point is, as I told you minutes ago, that for us, it is easier now to approach to patients because they recognize their difficulties from a psychological viewpoint. So the general framework for treatment that sometimes is difficult to sell to the patients who, you know, are sometimes still requiring for those occlusal related stuff, okay, is easier to convey. So paradoxically, the treatment outcomes haven't been lower than in the past.
I can add a little bit. In my practice, I noticed increase in the prescription of trazodone to improve the patient's sleep, which is not unusual for me to prescribe this, but in the past probably 3 months, very high percentage of my patients been placed on trazodone for sleep.
Any other interventions, anybody in the group, medical interventions or other medications?
No, I would say in our practice, I think patients are more apt to consider use of medications on a short-term basis that maybe they were before. And I think we're getting some patients that are not long-term TMD or orofacial pain patients, maybe that during this last year it started to present, and so they're seeking care now. And I think those patients, because of the lack of chronicity of their problem, they seem to respond a little bit better. So I think we're having some success with standard TMD care and patients benefiting right away, which has been encouraging in some of those patients. And of course, the patients that have been showing up that maybe were patients 8 years ago and now they've come back, they probably are not responding as well as we would like and are going to require some more comprehensive treatment.
Right. And then go ahead, Dr. Boguero.
Well, in our clinic, from a psychological standpoint, we offer a brief protocol. It's 3 sessions long. It's a physical self-regulation protocol. And what we do is we introduce clenching awareness and proprioceptive awareness training and diaphragmatic breathing. And what we're seeing is that we've had to focus on all those things, but also a lot more on the managing of the anxiety and depression. And we've also had to shift our treatment a lot more towards focusing on sleep, so much that we've now developed a brief 3-session sleep protocol. And that's largely due to the increase in sleep disturbance that we're seeing as well. And part of the question was on outcomes, and one of the kind of paradoxical things that we've been finding in our clinic is because we're doing all the psychological interventions over telehealth, we're seeing about 3 times as many more patients than we were at the same time last year. So we're actually seeing patients are much more willing to access the treatment, and they're about 25% more likely to actually complete all 3 sessions of the treatment. So we're getting better access and better compliance with the treatment, and that's been really encouraging to see.
Thank you. And
Let me also add, I'm not sure that everyone is familiar with the term social determinants of health, but these are specific questions you may actually want to begin including in your documentation regarding a patient's access to housing, food, transportation, utilities, childcare, employment, education, finances, and personal safety. And I have to emphasize the personal safety issue because we do see our share of patients who are subject to abusive relationships that may be enhanced by the fact that everybody's clustered together in their own housing setting, which can not only increase the intensity of the interactions between patients and their significant others, but also can lead to physical violence that might have an impact on their orofacial pain complaints. So we need to keep those elements in mind. And interestingly enough, the recent changes in CMS documentation for office visits, outpatient evaluation and management includes social determinants of health. So you may want to look that up if you haven't already.
it's a very good point. And I'm curious, Dr. Cohen, you had mentioned yesterday your observations regarding patients' ability to see physical therapists. You want to comment on that?
Right. So early on, then anytime we wanted somebody to go to physical therapy, then they couldn't go. So we had to take more of a role of doing a little bit more in-house training. But then a lot of the physical therapists started to do telemedicine. So it's important for everyone to check if they want to be referring to physical therapy to see if the physical therapists that they are working with do accept telehealth, and that actually makes it easier. So for a lot of these things, and I know that's the one of the next topics that I can reserve my comments on telehealth for that, as it's pretty significant. But in a lot of ways, as Dr. Jarrow pointed out, is that it's increased the ability for patients to go to physical therapy and even some of the referrals. A lot of the sleep medicine physicians are doing their follow-ups on telemedicine, neurologists, a lot of people where it's based on history. So you don't have to leave your house. You can just do it that way. But we'll talk about more about that on telehealth. But initially, the physical therapy was limited, but now it actually can be increased, and patients are taught how to do some things to themselves that the therapist would have done. It's not as great, but at least they have a better availability to it.
Very good. Let's talk about telehealth. I think this is good timing to start talking into telehealth. Have you had the opportunity to provide telehealth services, and how useful do you think it is, and what value do you see in it?
Well, as long as I'm on already, and then certainly want everyone else to comment, but I have found that, especially for our history-based exams, that if we have very limited office visits to procedures and doing specific palpations to confirm diagnosis, there is a tremendous amount that can be done with telehealth. And I was surprised to see how great it was to just talk with a patient, very private. They're very willing to share everything in this environment. They're comfortable in their home. And I actually prefer with a lot of these patients to do the initial evaluation via telehealth. And then if we determine they have something that they need to have treated, then they can come in and finish up the exam and take impressions for appliances or do injections. But there's a lot of self-palpation. You can watch them open and close. You can get a pretty good idea of what's going on. Their self-palpations can even reproduce their chief complaint. And in the follow-up visits, those are very helpful. So a lot of what we do in pain can be handled just like with psychology over telehealth. So the biggest problem I've had with telehealth is getting patients to do it because a lot of them aren't comfortable with the mechanics of it and, getting used to doing that. But I'd like to hear what everybody else has to say, but I have a good feeling that once the pandemic is more under control, we're still going to want to use a good deal of the telehealth measures. The reimbursement for it, I'm not really sure. And certainly I'd like to hear from all the panelists and through the chat maybe of how people are getting reimbursed for the telehealth, but I prefer it for some of these issues.
I just like to add a couple of things while we are talking about telemedicine. It is really very important that if the patient is not getting better and you cannot see the patient, don't wait till you see him. So he can or she can go somewhere else who are able to see him. It happened with one patient where at the beginning of the pandemic and everybody was afraid to open their practice, patient developed limited mouth opening and pain. Then when we were not able to see her, she went to an oral surgeon who was seeing emergency patients and he found a cancerous lesion in the mouth, in the throat area. So these are really important factors for us, for our patients. We should not ignore their symptoms if we can see them on face-to-face. So we should bring them back to us, to our practice, to see them periodically.
Yeah, I can comment on how the telemedicine has affected our practice. About 30% of our practice now is telemedicine. And for instance, say with our sleep apnea patients, we're asking them to have their initial visit via telemedicine. And then, their second visit can be a very productive one where they've got their prioritization for an appliance and we can take imaging and all those things on that first visit. But Orofacial pain at Mass General Hospital is really one of the first practices that went to telemedicine in mid-March. And it kind of saved our practice. We were able to probably keep about 50% of our patients that were scheduled on the schedule just doing telemedicine. So it was pretty effective. And then we've also found that, that the payers are paying quite well for telemedicine. And recently in Massachusetts, I'm not sure how it's going to apply to the rest of the country, but for the next 2 years, telemedicine visits are going to be paid at the same level as regular clinical visits. So I think, the other thing I would say is probably about 50% of our patients really want to do telemedicine. So if you don't offer it, they're going to go someplace else, but also they're very satisfied with it. And now that people have had an experience with it, and they realize they don't have to drive into Boston, they don't have to take mass transit, they don't have to expose themselves, it just seems to make a lot of sense. So I think it's going to be a part of every one of our practices to some extent. And one of the interesting questions is, as Rich alluded to, is I think you can diagnose a new patient pretty well. There's the policy has been that you shouldn't see consults for telemedicine, but you should just be seeing follow-up patients. I don't think that's true. I think we can do quite quite a good job in diagnosing patients and coming up with appropriate treatment plans initially. Generally we go to the clinical exam to confirm our suspicions, in our interview. So, I think we can do a really good job of evaluating and treatment planning these patients initially via telemedicine.
And I want to jump in here because I think one of the concerns sometimes we have is whether patients would be able to, they have the technology or the technical knowledge to access health this way. And I know from my own data of the over 60 patients I've seen since July in the clinic, only 2 have preferred to do this in person because of difficulty with technology. So I'm finding, at least from a psychological standpoint, patients demonstrate a very strong preference towards telehealth versus in person. And a lot of these barriers about technology are not things that have been major concerns, at least in my particular experience.
Anecdotally from Vermont, I'd like to point out that we have patients that have to get in their car, drive to a cell phone tower, and then contact us via telehealth because they don't have the ability to use internet access from their home. And so many times we're dealing with telehealth via cell phone rather than by computer. It does tend to compromise things. Another thing I would like to point out is that there's something about a face mask that interferes with our ability to assess, diagnose, and treat patients. So when they come in with a mask on and they spend perhaps an hour or so discussing their problems, you're looking at them like this, when in fact we should probably be looking at them like this. So under the circumstances, we encounter situations where we don't get the information we're looking for simply because of the use of a mask. When it's on telehealth, there's no masking involved, so at least you can see the face that you're dealing with and have a better sense of jaw function and mobility during that interview.
I think age of the patient has a lot to do with their ability to use the telehealth too. We have a lot of Medicare patients in both our private practice and especially in the dental clinic. So the younger patients have no problem with it at all, and some of the older patients do. And then just a brief comment on reimbursement, as I haven't seen it yet, but because of the new guidelines, since it's the MDM is the only thing they're working as the management, is the credit for these office visits is based on that rather than on exam and observation. It really should help reimbursement for telemedicine. What do you think about that, John?
Interesting point. I think that it's something we have to contend with on a daily basis. And one of the things that I have theorized on in the past was how much transition would be involved in converting into a telehealth protocol. From my personal perspective, I think that we're dealing with a patient population where we do have to see patients at various different times to assess their situation. We can't just do it all via telehealth approach. When it comes to Dr. Bulgario, he can see patients very nicely because he's not dealing with the structural issues that we encounter. And one thing I wanted to point out today was that if you see someone with facial flushing because of an autonomic response to their condition, shall we say, how are you going to assess that patient if they have a mask on? So I saw someone just this past week who has a autonomic cephalalgia, and in her particular situation, the use of the mask completely obscured a lot of the initial signs that we were looking for. So I think we have to keep in mind that there's more to this than just musculoskeletal pain. There's a lot of other factors that are at play too. I don't know. Did I answer your question?
I like to add something that I noticed myself wearing the mask, and sometimes I wear the shield, that I'm yelling more, I'm talking louder, and I'm not hearing myself also. So it's frustrating to us as physicians or dentists that dealing with patients also wearing masks, and sometimes these patients have hearing problems. So it is really frustrating to all of us. That's from my personal experience.
Let me also comment that if you're hearing challenged, as I am, wearing dual masks really does tend to complicate the problem. So being able to understand people face to face can be very compromised, as opposed to a telehealth situation where you can adjust the volume and lip read as needed.
And I would say that, as Dr. Schaefer said, I also don't have an issue in doing telehealth with initial patient exam and follow-ups. I know that maybe some providers are concerned maybe about the medical legal aspect of things, like what if you miss an oral cancer or something really obvious. It has its limitations, and that's we should certainly put that explain that to the patient, document accordingly. But I do think that by giving the patient the option, you'll increase the chance the patient, even though they may not feel comfortable coming in, look, what we do, 50%, maybe more of the time in the chair is taking history. So you say, look, let's get all of this done. When you come in, we're going to confirm everything. Maybe we'll do a procedure. Maybe we'll do a trigger point injection, the low-hanging fruit, something like that, or a steroid injection, whatever it is. So instead of coming to our clinic or your private practice, you don't have to come for an hour, hour and a half. You can just come in. By getting all this out of the way, patients will feel more comfortable. I can't say I've done 30% of our patients telehealth, but we do have a couple a week. The challenge is, I've noticed that I can't have a telehealth visit in the middle of my schedule somewhere. That's I put all my telehealths when I'm in my office all in a row. I can't jump back and forth. I'll run 10, even 15 minutes behind. You can't leave a patient hanging. So you really, at least in the way it's worked out for me, I have to have telehealths all in one group in time period and patients in person in one time period, so to speak.
Yeah, that's what we do. I schedule afternoon hours for telemedicine. And we usually see one or two patients every day in the afternoon.
For my experience, much depends also on the patients. Here in Italy, we have, of course, a different healthcare system. So we don't have, or almost don't have, insurances. We may have, Dr. Armand pointed out, medical legal problems, just relying on telemedicine on distance. But there are also cultural problems to perform a first visit via telehealth, because here most patients are thinking to need for a neonatologist. Sorry for using this term. So still thinking about dental occlusion, disreposition strategies. So it is not easy to make them understood that they are dealing with a psychologist or a pain practitioner, and anyway, a professional who just need to listen to the anamnesis and to the history to steer toward the proper diagnosis. They are used to be visited. Okay, so telehealth and sometimes even text messages with our patients are very good for the follow-ups, but not for the first visit here, at least for my experience.
I have a question on telemedicine for everybody. Is, the hours that you have telemedicine, now that so many people are working at home, do you need to have an evening hour? Or will most people be able to schedule it during the day because they're working from home?
Yeah, at home. I've never had anyone even request. The one caveat with this, and again, totally a separate point, is do you have to use a HIPAA compliant platform? I know some patients ask, hey, can I FaceTime you? And I typically say that, no, we have to use our, HIPAA compliant aspect, our programs.
We
But
do as well. We go through the Epic system.
yeah, but yeah, to answer your question, no, I've actually never had anybody ask like for 7 p.m. or 8 p.m. Work hours works for everybody.
Yeah, we've done a 3 to 7 p.m. telemedicine clinic every week, and so, I mean, some people shoot for the 3 o'clock, and some people shoot for the evening hour. I guess it depends on whether they're teaching kids at home or they're waiting for their spouse to come home so they can have the appointment or what. It seems to make sense to have some evening hours.
So overall, what we're hearing is that at least the panelists see value, significant value on telehealth, but there are also some possible medical legal concerns and perhaps having some protocols that could be established as to how to make sure we're not missing any diagnosis or generating adequate treatment plans might be helpful, as it seems like telehealth might be with us for a while longer, at least, if not for a lot longer. But unless you guys have any other comments, I think we should move into the Q&A. Gabby, have you seen any questions that you'd like to start bringing up to the panel? Oh, unmute, Gabby.
I would just say one thing while he gets unmuted is that you do have to be concerned about being licensed in the state that the patients you're interviewing, so you can't go out of the state. I don't know if that's going to change, but that is a concern. So we can only do telemedicine with someone that's in the state of Massachusetts, which is a big concern for us because many of our patients are referred from, the local states. So that's.
I believe as long as the address of the patient is within your state, even if at the moment of the visit are in a different state, it's okay.
And also, it's a follow-up patient. If you've done the consult in Massachusetts and they've gone to Florida for the winter, you can still get paid to see them.
Right.
But, I mean, obviously you can still see them, but you're just not going to get paid, which is a problem, of course.
Okay, I see a question.
I have a question here from, I don't know if Michelle, have you performed more Botox injections and other trigger points injections since COVID? I'll answer from my experience. I have my Botox patients already set. Yeah, I do have some requests from other patients to do Botox for their teeth clenching and muscles tightness. Actually, more trigger points, yes. I am doing more injections these days than before. I did. Anyone would like to comment?
I did not.
I have a question from Jose de la Hoz from Spain. What's your feeling about the confidence that patients express in their visits to our practice now?
Let me say hello to Jose. Hi, Jose. My feeling is that our patients are pretty confident in our safety level. I don't see any difficulties or skepticism by their side.
I say hi to Jose as well. No, if they see that we're taking all these precautions, they're encouraged by all the questions we ask and all the PPE that they see. And of course, those are only the ones that show up. The ones that show up seem very comfortable. Some of them are watching to make sure that we're doing everything. And if we go to touch something and they see anything that they are worried about, they do actually say something about it, which is good, although some of them seem to be a little more paranoid about it than usual. But a lot of the ones that are uncomfortable, we don't see. They just don't come in, or they verbalize to us that they're not comfortable coming in yet, particularly ones that have elderly, either if they are elderly or they have an elderly person living with them, they're holding off and they're doing more of the telemedicine visits.
I'm trying to choose certain questions from around the world. Camille Haddad from Lebanon when we postpone an office work and we are doing telemedicine, aren't we making things worse? Any comments? Are the patients complaining more, or?
You clarify that is that are making it worse by doing telemedicine?
Worse. Making it worse.
No,
Symptoms, potentially symptoms. One would think that patient's condition getting worse.
I don't know that they're getting worse up here. I think that there is a potential and delay for treatment, but I don't know that, I can't say subjectively that I've encountered people saying, oh, I'm so much worse because of the delay in access to care. I do see patients complaining more bitterly of their symptoms, but it's not an access to care problem. It's just the nature of the world we live in, I guess you would say.
A question from Hugo Diaz. Do any of the panelists have data on patients' feedback about telehealth video appointments?
I have some patients like it, and they ask for it actually, and we are doing it more often now, especially for sleep patients who are using oral devices. Instead of doing that mandibular advancement in the office, we give them the key and they do it. And every time they advance the mandible, they take pictures, or we do telemedicine with them to show us how much advancement.
I would just say that most of our patients, especially some of the initial consults, are just really pleased with the telemedicine consult. You know, we have a resident interview them first, and then I'll come in and talk to them, and they really feel like they're getting good comprehensive evaluation, and patients are quite thankful. It's been my experience, and I felt like I've been able to do a pretty good job evaluating them and treatment planning them. We've had a good interaction with the patients, maybe because they're not wearing masks, like Jeff said, you know.
I think one thing that has helped with telemedicine for me personally has been to make sure that patients that we're able to get any recent x-rays that they might have, dental or panoramic x-rays, ahead of the appointment, so that we're able to visualize those at the time of the appointment. Maybe they come from their general dental office.
I have important questions, good question from Anas Altai, probably from Saudi Arabia. Have you noticed an increase in neurological orofacial pain disorders such as burning mouth syndromes in patients with a reported history of COVID diagnosis?
He's in Minnesota, actually.
Oh, okay.
He's a resident from the U of M.
Okay, great.
Yeah.
Okay, you answer him.
I think we're getting referrals from all kinds of patients. We're getting a lot of referrals in-house at our hospital and stuff for neuropathic pain and TMD problems, and that seems to really be increasing across the board of all our patients.
Anybody else?
Any increase in particular about burning mouth syndrome for patients who were positive for COVID?
I would say no for specifically burning mouth. I think the burning mouth patients that we've seen are ones that have had it for a while and are seeking care again. So maybe the stresses of the pandemic are making their symptoms a little worse. But I haven't seen an incidence of new burning mouth patients myself.
I think it's going to be a while before we get a true impact of it, as we see a lot of patients who've had COVID. Right now, we haven't in either clinics, but in this next year, we definitely will. There'll have to be some studies. There will be, to see what the impact of COVID has been on all the different pain conditions that we treat.
I have to admit, up here we are seeing much higher incidence of patients that we've seen in the past. So they seem to be coming back a decade or even 2 decades later for reassessment of their problems because they've been doing well for a long period of time and now all of a sudden they're back in trouble again.
I second Jeff. I'm seeing it the same in my practice.
Yeah, okay.
Physical therapist comments. I believe she's a physical therapist. Gina knew we have had an uptick in referrals for physical therapy to manage the pain, symptoms, posture. And doing telehealth in physical therapy, finding to be about 25 to 50% as effective as in-person care.
I can talk from my next door physical therapist. He was seeing patients in the beginning of COVID till now. He never really closed the office. The number of patients were less, but we closed the office in March, and he kept seeing patients 2 days a week for their needs, because certain injuries, certain problems need to be addressed on a regular basis. So he never really closed. I know he does not do any telemedicine for physical therapy.
There's a question regarding billing fee for service through telehealth. Is it possible?
I can talk from my perspective. We do medical billing, and we bill a regular visit for the medical insurance, as long as everything is documented with the visit. Yes, we can.
And how fee for service? I assume that means cash, right?
I assume so. We don't encounter this. The majority of my patients are probably 99% are covered by insurance.
Anybody has experience?
I don't know. I think dental insurance is starting to think about covering telehealth, I believe. But I would guess if you're doing fee for service, you just have to make sure there's a good informed consent about what the costs are going to be and have people sign it so that you can collect afterwards. But, all my telehealth has really been done through medical insurance coverage.
Great.
Okay. What do you think, Mariana?
I think it's good. I think if the panelists would like to make any other comments, I think that'd be great. Otherwise, I think we should maybe wrap up.
Any final, comments from anyone?
Yeah, I'd like to make a comment. One of the things that strikes me from this conversation is how different everybody's experience is. And I think we have to be open-minded about applying the principles of what is necessary to deal with these circumstances for our individual environment and practices. I can't dictate what I do to anyone because obviously Vermont is an entirely different world than most of the rest of the world. And therefore, there may be lessons to be learned, but I'm not so sure that they can be universally applied.
I would just say that, I think some of the changes in our practice that have occurred during the pandemic are going to stay with us. One is telemedicine, but I think also some of the ways we're making patients safer. I mean, we have doors to all our operatories now. We're going to see patients more privately. We're going to wear face masks. All those things I think are going to stay with us because, the next pandemic is on its way. And I think that's something we have to be aware of, that these changes are going to be with us for a long time.
I think you're right.
But I was trying to figure out who the star of the panel was, and I think everybody did such a great job. I was really impressed with the organization and ability and all the comments we made, or everybody made. It was really, really well done.
I really like to thank you all for your wonderful participation. The panelists, Mariana, you are great. You did wonderful. And to the American Academy of Orofacial Pain for allowing this to happen, and really it's great. I like to thank everyone who attended the webinar for putting the time to listen to us. I know two different part of the world, and we wanted to have more international presence, but Daniele, with his great experience, we thank you a lot, Daniele, for your input, for everyone individually. I don't want to mention, I can mention all the panelists, they are here on the screen. And I'm okay to adjourn.
I'd like to say thank you also to the panelists and to the attendees. I hope it was a productive meeting. Thank you, Gabby, for having the initiative to suggest that we had this meeting, because I think it was very valuable, or I hope it was valuable. And yeah, I hope everybody has a good weekend.
Thank you. Thank you, everyone. And have a wonderful weekend. We'll be in touch.